So I think I've been given another epidemic topic in that FAI was something certainly that I hadn't heard of when I first graduated 20 years ago, but over the last decade is something that's become more and more prevalent in sports physiotherapy. So first of all, the definition of what we now call femoroacetabular impingement syndrome, or FAIS. Griffin et al. In 2016 proposed the Warwick Agreement. It was a consensus of a number of experts in the field, and it's subsequently been absorbed by 25 different clinical subgroups. And it was defined as a motion-related clinical disorder of the hip representing abnormal osseous contact between the proximal femur and the acetabulum. However, the definition is stringent that it's defined by a triad of symptoms, clinical signs, and image findings. So first of all, the morphology. Thank you to Kieran earlier for giving us the visuals on the radiology presentation. There's 3 different types of FAI morphology. CAM is the most common, and it's excessive bone growth at the femoral head-neck junction in the anterolateral aspect. The pincer morphology is excessive bone growth on the acetabulum, and mixed is obviously both. But as you can see, it's actually present in a number of asymptomatic individuals, so it's certainly not indicative of symptoms. It's present in 25% of asymptomatic non-athletes, 50% of symptomatic non-athletes, but 66% of athletes regarding whether they have symptoms or not. This increased prevalence is deemed to be due to excessive flexion, rotation, loading patterns during skeletal maturation. And of particular pertinence to all subgroups is the fact that a CAM morphology can lead to an increased prevalence of OA at 6 to 25% incidence within a 5 to 19-year time pattern afterwards. But as we see in other sports medicine issues, sometimes morphology or image findings are not indicative of symptoms. So at the time the Warwick Agreement was proposed, an editorial in the BJSM proposed a possible pathomechanism as to how this can relate to symptoms. So what they suggested was that dynamic hip joint instability could lead to excessive femoral head translation, causing repeated mechanical loading of the acetabular labrum, structural alterations and upregulation of nociceptive activity, hence causing sensory motor effects and altered neuromuscular function. But in a condition that's been very much deemed biomechanically, we mustn't forget our other biopsychosocial factors. So in a study by Westerman, he also identified these other patient factors, being smoking, lower activity levels, female gender, and poorer mental health status, all having a negative impact on symptom progression. And in fact, they had a stronger correlation with hip pain and function than intra-articular findings at arthroscopy. So, first of all, what impairments are related? So this is from a systematic review done in 2015 by Frake, and already it is in conflict with what Pat and David reported earlier. It was a meta-analysis with a number of heterogeneous studies. They excluded quite a number before they analysed the subsequent. So with regard to hip range of movement, they found decreased ranges of hip flexion and, hip flexion and abduction with limited evidence. Sorry, all the things have gone a little bit out of line here. Whereas there was no difference with hip adduction and extension in external rotation and internal rotation. And obviously that's not in agreement with what David and Pat reported earlier. With regard to hip muscle function, there was moderate conflicting evidence that there was decreased strength of the adductors and the external rotators. But interestingly, in the female gender, there was decreased muscle strength in all the hip muscles, which then belies the question whether the research should take into account both male and female subjects. And then with regard to functional movements, there was a change in single leg squat ability, which was actually moderately significant. There's a further study, it just doesn't appear on the screen there, where trunk muscle function is also seen to be impaired in a study of post-op patients 12 to 24 months after their surgery. They had ongoing bilateral trunk muscle strength deficits, and that's certainly an impairment that's been taken up in the research. So, conservative management. As yet, we don't know which is the most appropriate method of management for FAIS, but the Warwick Agreement proposes that it should be physio first for everybody. And so what is conservative management? First of all, physio should be impairment-based, so make sure that you actually are aware of your individual patient's impairments. And thanks to Pat for providing us with a very detailed assessment. So make sure you know what ranges of movement are affected and muscle strength groups are affected in order to provide high quality, high value physiotherapist-led intervention. The next part of it is education. We must educate our patients regarding load management, awareness of impingement positions, and sometimes this can be to discourage the patients from doing what they think is helping them. Yoga and Pilates positions can sometimes be actually detrimental. Certainly the world's greatest stretch and things like that can actually be quite provocative for FAIS. Educate them on the pathoanatomy. As we've heard today, it improves the buy-in of the patient. It reduces the anxiety levels if they can understand what's going on. Educate them about their prognosis and reduce the threat factor of the subsequent development of OA. It only happens in 6 to 25% of patients, so it's not a definite progression. And discuss the treatment options with them. And with this comes expectations. And I think this is a condition that's very subject, again, to Dr. Google, social media, patient and parent expectations. Lots of people have an opinion on it. It's quite visible in kind of the sports setting. So you need to ascertain what are the patient's individual values and goals. You need to discuss with them the efficacy of physiotherapy versus surgery. Again, I'm sure Pat and David's results might contradict this, but the research says there's only moderate quality of life measures with both interventions, and regardless of treatment, the outcomes are likely inferior to the age-matched healthy controls. Now, I'm not sure that my clinical practice would agree with that either, but that's what the research says at the moment. But I think you have to be very realistic regarding the timelines for return to play and what can be expected from having either a surgical intervention or proceeding with conservative management. So, manual therapy. For the physios in the room, a lot of you know that this is a very hot topic in physiotherapy at the moment. But Chad Cook, one of the major supporters of manual therapy, would say that it certainly has a role for providing a window of opportunity for patients, but only if they demonstrate within session pain modulation effects, and if the patient is pain adaptive, it's appropriate to incorporate manual therapy for 2 to 4 sessions to facilitate early pain modulation while allowing them to develop strength and load capacity, and combine it with personalized rehab. And this is obviously the cornerstone of conservative management. As yet, it's a very heterogeneous, we don't have a standard protocol, so all the research is using heterogeneous exercise prescription, but it is agreed that it needs to be personalized, progressive, and physiotherapist-led and target individual impairments. And so there's been 3 RCTs over the last 2 years looking at the effectiveness of conservative management in FAIS. The first one, Mansell et al. In 2018, used military personnel. They randomized 80 subjects into 2 groups, 40 in physio and 40 in the arthroscopy group. The physio group received manual therapy and rehab exercise for 12 sessions over a 6-week period. There was a very high rate of crossover, and what they felt was that when patients or subjects had actually had a consultation with a surgeon, it changed their expectations so that they actually wanted to swap over to the surgery group. And because of the crossover rate, it made the statistical analysis very underpowered. And 58.1% did not perceive a clinically meaningful change at 2 years. The UK fashion trial, which had a much bigger subject group, 348, had 177 in the physio group and 171 in the surgery group. There, the physio group had manual therapy and personalized hip therapy, plus minus 1 hip joint corticosteroid injection for 6 to 10 sessions over 12 to 24 weeks. And both groups statistically improved. There was an adjusted mean difference between the groups of 6.8 on the IHOT 33 outcome measure, which is a relatively small point difference when you take into account the risk and financial cost of surgery. And then finally, Kemp has done a feasibility study called PhysioTherapist with just 24 subjects, 17 in the physio group and 7 in the control group, again using manual therapy and an FAIS-specific rehab over a 12-week period. And they found a large effect size for strength gains in all hip muscles and trunk improvement, with clinically meaningful improvements in pain, function and quality of life. So that's a much more promising study, and they've gained feasibility now to run it as a much bigger RCT with 144 subjects. So as yet, we're still unsure which is the best way to go. Thank you.
Thank you very much, Colette.